Once you establish safety, that was my number one concern. The next thing is you want to see well. You don't want to do this and just be so-so. I didn't, and I was blind, but I wanted to see well. My goal was to pass the MVI test without glasses. I wanted to pass that test. And I waited and watched the international community from the time we went down to visit those first 15 crazy people in New Orleans through the time when some of the Brits and the Canadians were getting excellent results, even with people as blind as I was. They weren't even doing people like me in the mid-90s in the United States. I had huge astigmatism and nearsightedness. Okay, they weren't even touching people like me. We hadn't even begun to think about doing people like me in the U.S. But some of the Europeans and the Canadians had done enough that they had perfected the technique and the program, learned how to program the laser to get good outcomes. And I was waiting till 19 and 20 or 95% of the people that were as blind as I was were seeing to drive with the first try. Okay, by mid-94, 3 people reached that mark. I tried to figure out why they were so good, because there were about 25 really good surgeons in the world at that point. Why were these 3, 1 German and 2 Canadians, better than everybody else? Significantly better. I figured it out, and it was a valuable piece of information. They all saw their patients preoperatively. They made sure all their equipment was calibrated to take in measurements exactly the same. Their staff was trained to do it the same. And then postoperatively, they saw their own patients. They followed them up in their own clinic, collected that data, and used those numbers to crunch the numbers. And they figured out how to program the laser based on that experience. Most people that do LASIK surgery in the United States today take the numbers, if they gather them at all themselves, somebody usually sends them to them, they plug them in the laser, it tells them what to do. In a case like our young man tonight, if Kev would have had that done that way, 50% of the time he would have seen the way he wanted to the first try with plug and play. But having learned how to program it and having tracked data for so long and done thousands of people like him in that range, he's in the moderate range, in the 6 to 10 range. He's got about a 95 to 96% chance that he will see just as well as he could have possibly hoped for with 1 try, with the way we've learned to program that. Now, I wish I could say it's because we're gifted that we can do that, but here's the reason we get those outcomes. We track data like demons around here, and we are obsessive compulsive about it. And we have a staff that do nothing, so half Tammy's time, I think, and Jamie's time is putting data in the computer from follow-up visits. Why do we do that? Because I watched the Brits and the Canadians in the days when they do 50 eyes in a week in a busy center, and if 5 of them were right, it was a banner week. 45 of them were way off, 5 of them were close. And I watched them go from those days to when 19 and 20 were right. And the way they got good was they tracked their data and they learned to program their laser based on their experience with their machine and their environment, and that's how they got good at it. And if you want to be good at this and have good outcomes, you need to do that. Why doesn't everybody do it? Because it costs a lot of money to track data. Number one, we have to see you and follow up. That takes up clinic time. That takes up our time. And we typically, as surgeons, will see you ourselves on the first day and the first week visit. And then depending on how you're doing, we may collect data 1 month, 3 months, 6 months, and a year. But the 1 day, 1 week, 1 month, and 1 year visit are absolutely essential. I don't care if you're 2015, 2012. You've got to come back for those visits. Why? Because it's only that good for you because all the people before you came in before you, okay? So if you're not willing to keep the follow-up visits, don't come here, please. Go someplace where they don't care about tracking you, okay? That's up to you. But we want to see you back, okay? Now, outcomes are critical, but if you ever go to a doctor and they promise you an outcome, if I tell you guys, if I sit down with you and I say to you, I can tell you, I promise you, you'll be 20/20. You ought to run because I'm lying. I can't promise you that. No one can promise you that. No one's done you before. The only way I can tell you exactly how you'll do is if you have an identical twin and we do them first. Then I can tell you exactly how you'll do. because the components that make up how you see after this are twofold. Mostly it comes out from how we program the laser. And we figured out how to do that pretty well. But the second component is there's a small strand of your DNA on one of those 23 sets of chromosomes that's going to tell those eyes how to heal. And we know in Kevin's range there's about 4 or 5% of the people we do that are going to heal aggressively. They're going to hit the mark initially, but they're going to heal aggressively and backslide on us a little bit and end up a little nearsighted or astigmatic and have to come back and get it touched up. Get it enhanced, get it tweaked, get it two-putted. I don't care what you want to call it. But they're going to have to come back and do that. And when I sit with you or Bob or Nilu sits with you, we can't tell you if you're in the 95, 96% or you're in the 4%. We don't know that. But we can give you the odds based on your power and your correction from our data. And so you'll know what your odds are. Then you put those odds in your head and you say, this is the risk-benefit scale in my head for my eyes. Does this make sense to me for my eyes? And if it does, go ahead. And if it doesn't and you're not sure, don't do it. Only you can decide if this is right for you. And that's why if anybody tries to talk you into it, or if anybody promises you an outcome, my best advice is don't do it.